Okay, thank you very much. I will be talking slowly because the audio is not that great. I hope you can understand what I'm saying. So my name is Tina Sichrovsky, or Dr. Tina, as many people call me, and I will talk about the first part of our little conference here, and my topic is atrial fibrillation. So atrial fibrillation is the most common arrhythmia of the heart. It is a usually irregular and often fast heartbeat that gets created in the upper chambers of the heart, and more specifically in the left upper chamber. If you look at this picture here on the left-hand side, you see a heart in normal rhythm, so-called sinus rhythm. The heart is mostly a muscle, but it only beats if it gets a signal from the electrical system of the heart. That electrical system starts here in the right upper chamber. There's a bundle of nerve cells called the sinus node that sends electrical impulses in a rhythmic fashion. The heart rate is depending on what you're doing. If you're resting, it's around 60 beats a minute. When you're active or emotionally stressed, then the heart rate goes up. But it should only get created here in that small area of the right upper chamber. From here, the electrical impulse spreads. It spreads to the left upper chamber and travels down to the pumping chambers. And as a result, you see here a nice regular rhythm called sinus rhythm. You see this little blip here that gets created when the upper chamber speed, followed by a spike when the pumping chamber speed, and then everything relaxes. And this repeats itself in a regular fashion. If you look on the right-hand side, this heart looks very different. Here the upper chambers are in atrial fibrillation, which means that many areas send electrical signals at the same time. It initially starts in the left atrium and then it spreads to the right atrium as well. Now all those extra beats are trying to go down to the pumping chambers and create a heartbeat. And as a result, the EKG looks very different. You see here, the upper chambers are just quivering, and then the pumping chamber speed whenever a heartbeat makes it through the conduction system down to the pumping chambers. What does atrial fibrillation feel like? Well, it's very different from one person to another. Many people are very sensitive and can immediately tell that something's wrong. They feel palpitations, they get short of breath, they may feel weak or dizzy. Other patients feel very little or have very vague symptoms and may only get diagnosed on routine exam or only when a complication develops. In the early stages, atrial fibrillation often comes in bursts in self-limited episodes, which we call paroxysmal atrial fibrillation. Those usually progress over time if we don't intervene. Those episodes become more frequent, they last longer, and eventually people progress to something we call persistent atrial fibrillation, which lasts for several weeks to months, or even become permanent or chronic, lasting for several years. Talking about complications of atrial fibrillation, there are two major complications. The most serious ones are congestive heart failure and a stroke. Congestive heart failure can develop when atrial fibrillation is present for many weeks or months, often in people who are not immediately symptomatic. And when the heart beats very fast for prolonged periods of time, it gets overwhelmed. And the heart muscle can become weak and dilated. If you look here, this is a picture of a patient in congestive heart failure. The left ventricle, which is the chamber that pumps the blood into our circulation, has become very thin and enlarged, compared to a normal heart where the chamber is smaller and the muscle is thicker. This is a process that takes many weeks to months, and it's usually reversible once we restore normal rhythm or slow the atrial fibrillation down. Another serious complication of atrial fibrillation is a stroke. This happens when the upper chambers are in atrial fibrillation for a long time, and instead of the blood being pushed in an organized fashion to the bottom chambers, when the upper chamber speed very irregular, the blood can stagnate and little clots can form, and if they break off, they can go to the brain and cause a stroke. What are the causes for atrial fibrillation? Well, there are many triggers and risk factors that make atrial fibrillation more likely, but there's not one single cause of atrial fibrillation. The most frequent triggers that we encounter are obesity and sleep apnea. But other factors are high blood pressure, valve problems, thyroid problems, alcohol, and stress. And you will hear a little bit more about sleep apnea from my colleague, Dr. Musat, later on. What are the treatment options for atrial fibrillation? We usually go through a different, a staged approach, starting by treating triggers and risk factors. As I mentioned, obesity and sleep apnea are very often involved. Then there are medications we can use, and I will go over them in a little bit. There's something called a cardioversion, which can restore normal rhythm with an electrical shock. And then there are procedures like an ablation procedure or surgery. There are three different categories of medications that we use. One group is called rate control. The next group is called rhythm controlling medications. And then there are blood thinners. Those are usually designed to prevent the stroke. Rate controlling medications are very simple medications that are many people use for other reasons like high blood pressure. Some of you might be familiar with some of them, like metoprolol, carvedilol, diltiazem, digoxin. Those medications don't change the rhythm, but they slow down atrial fibrillation and protect the pumping chambers. Rhythm controlling medications are so-called antiarrhythmic drugs. Those can restore normal rhythm and maintain normal rhythm and basically buy time, but they don't cure atrial fibrillation. They're just controlling the situation, and they don't usually work forever, and many of them have side effects. So they're often used as a bridge to something more permanent. And then blood thinners are just medications that make it harder for the body to form a blood clot and therefore reduce the stroke risk. Cardioversion is a procedure we often use to restore normal rhythm in people who are in persistent atrial fibrillation. So atrial fibrillation, if it doesn't stop on its own anymore, we call it persistent atrial fibrillation. Cardioversion is a shock procedure that can be safely done if the patient is on blood thinners. It's done under sedation. It's not painful because you're asleep. It usually resets normal rhythm. You see here the patient is in atrial fibrillation. The shock restores normal rhythm, but it's also a short-term solution. It does not prevent atrial fibrillation from recurring. If we move on to more permanent solutions, the most effective way of treating atrial fibrillation is an ablation. And what we use most commonly is a so-called pulmonary vein isolation. This addresses the source of atrial fibrillation, which are the pulmonary veins, which are located in the left upper chamber. Those are just tubes that bring the blood back from the lungs into the heart, but the cells in the opening of those veins are the cause of atrial fibrillation in the early stages of the disease. We nowadays mostly use this kind of ablation catheter. It's a catheter that has a balloon at the tip. This balloon is initially collapsed, so the catheter is very thin in the beginning. When we go into the opening of the vein, the balloon expands, touching the inside of the vein, and then the balloon gets very cold, freezing the tissue where it has contact, and it causes a thin rim of scar in the inside of the pulmonary vein, which electrically isolates the vein. So if the cells further down send signals, it's electrically blocked here and they can't put the heart back into atrial fibrillation. We perform this it's called cryoablation in each vein until all the four veins are isolated. This is very effective in patients who have paroxysmal atrial fibrillation or early stages of persistent atrial fibrillation. The success rate is about 80%. It's a low-risk procedure. The risks are about 2 to 3%. And it works the best in patients who have their risk factors already addressed, like obesity, sleep apnea. All those things need to be addressed at the same time, otherwise the success rate will drop. What do we do with patients who are very difficult to control? Some patients don't get diagnosed early on and have been in atrial fibrillation for weeks or months at a time. It's very important to know that the longer the heart stays in atrial fibrillation, the more it gets used to it and the more likely it wants to go back into atrial fibrillation. We call this remodeling because the upper chambers start to stretch and dilate and the muscle fibers get disorganized the longer the heart stays in atrial fibrillation. It is still possible, however, to cure atrial fibrillation in those patients. You just need more time, and we often use a stepwise approach. So important, as I mentioned before, is always to treat triggers. You have to treat obesity, alcohol, stress, sleep apnea in order to be successful. Then we can use one of the rhythm medications to suppress atrial fibrillation for a couple of weeks, often with the help of a cardioversion to restore normal rhythm. and let the heart learn how to beat normal again. Sometimes we wait a month or even 2 months in normal rhythm before we then proceed with an ablation procedure. Giving the heart time to learn how to beat normal again lets all those changes that took place reverse themselves. And we call this reverse remodeling. And we often use little recorders to make sure that the patient really stays in normal rhythm for all this time. And if we then do the ablation, the success rate goes up again, close to 80%. If it still doesn't work, if you still think that the simple ablation is not enough to cure atrial fibrillation in certain patients, especially if they have been in atrial fibrillation for a very long time, or if they have already failed an ablation procedure, we often use something called a hybrid ablation. This is a two-part procedure where we do the pulmonary vein isolation, as I described earlier, but the surgeon comes in with us and he ablates the back wall of the atrium, of the left atrium, which can also be a source of atrial fibrillation in a later stage when the person has been in atrial fibrillation for longer periods of time. This is not open heart surgery. It's a very small incision under the sternum, under the breastbone, where this clamp gets inserted and the back wall gets ablated in a more complete fashion. By ablating the back wall and the pulmonary veins together with those two procedures, the success rate can be as high as 80 or 90%, even in people who have long-standing atrial fibrillation. Then we have different procedures available that are part of clinical trials, like the MACE trial, where the pulmonary vein isolation gets combined with eliminating or ligating the left atrial appendage, which can be a source of clots, but also be a source of atrial fibrillation. And the second trial we have is the iClass trial, where we use a different ablation catheter for both the pulmonary veins and the back wall of the left atrium, with a different ablation catheter that looks kind of like this, like a corkscrew, that also uses freezing for ablation. That's my talk. I'm gonna hand over to Dr. Bhatt, who will talk about blood thinners and stroke prevention.
Dr. Bhatt, you just have to unmute yourself.
How's that?
You're good to go.
Good evening. My name is Advay Bhatt. I'm one of the heart rhythm specialists at the Snyder Center for Comprehensive Atrial Fibrillation. I'll be talking to you about reducing your risk of stroke with atrial fibrillation, in particular anticoagulation and other device-based procedures to reduce your risk of stroke, such as a device called a Watchman device. So I think the cornerstone of treatment for atrial fibrillation is stroke prevention. We can focus on symptoms with ablation and medications like Dr. Sichrovsky mentioned. We accompany that with lifestyle modifications, but underlying all of that is stroke prevention, because strokes very rarely ever have any warning, and they can be devastatingly large, disabling, and deadly. And ultimately, if we can make atrial fibrillation go away, that's a huge benefit. But in some cases, we can't. And there's this long-standing risk of stroke that we need to manage over time. So there's about 6 million people with atrial fibrillation in the US, and this is due to double over the next decade. And patients with atrial fibrillation are at a 5 times increased risk of stroke. And about 1 out of 6, nearly 20% of strokes occur in patients with atrial fibrillation. And patients with atrial fibrillation also have a 2 times increased risk of recurrence of stroke. So this is a very big problem that we need to try to solve going forward. The thing to be aware of, these strokes are the #1 cause of adult disability. You have atrial fibrillation-related strokes, you have a 1.5 times increased risk of disability, 2 times higher mortality rate of dying from a stroke. About 70% of these strokes result in death or some form of permanent disability. That might be visual impairment, cognitive deficits, depression, social disability, aphasia or inability to speak, hemiparesis, meaning inability to move an arm or leg, or both, inability to walk unassisted, incontinence, or inability to work because of residual symptoms of stroke. And as Dr. Sichrovsky mentioned, you have this hurricane in your heart when you have atrial fibrillation, where the top chambers of the heart are beating fast, erratically, and inefficiently. It leads to pooling or congealing of the blood, also increased activity of the clotting system, and the lining of the heart and blood vessels are less effective at preventing blood clots. And in the end, what will happen is you can form blood clots in this particular pouch in the heart called the left atrial appendage, and that's the source of greater than 90% of the blood clots. And what you might see here in this image, which is an echocardiogram, you see the little pouch here, and in it there's this little white round ball. That's a blood clot there. And what can happen is, as the heart continues to beat erratically, pieces of that blood clot could break off and go to the brain or elsewhere in the body. And in particular, the one that goes to the brain is called a stroke that can lead to devastating consequences. So ultimately, is how do we reduce this risk of stroke? The primary way we think about this is with blood thinners, but to be mindful that blood thinners, by virtue of how they work, they thin your blood, they prevent blood clots, prevent strokes, but they also increase your risk of bleeding on the other hand. So we have to balance those risks, and depending upon someone's risk score, we may choose to put someone on blood thinners or not. And here's a simple risk score that we use for all our patients with atrial fibrillation called the CHADS-VASc score. The C in CHADS-VASc stands for congestive heart failure. H stands for hypertension. A stands for age. You get 1 point if you're over the age of 65, a 2nd point if you're over the age of 75. D stands for diabetes. S stands for stroke, where you get 2 points if you've had a stroke before. V stands for vascular disease, where you get a point if you've had a heart attack, you've had blood clots before, or other types of heart blockages, or blockages in the arteries in the neck, legs, or arms. And then the last part is gender, S for sex. Women get 1 point since women are a little bit higher risk of stroke than men. So generally, when you have a risk score of 0, no specific blood thinners are needed. The risk of bleeding on a blood thinner or an anticoagulant is higher than the risk of stroke. Also, in this circumstance, aspirin is not thought to significantly reduce the risk of stroke, but does increase the risk of bleeding. Whereas if you've had a score of 2 or more, two or more in men or 3 or more in women, at that point, the benefits of being on a blood thinner outweigh the risks of bleeding. So your options are either medications like warfarin or what we call direct oral anticoagulants, newer medications such as Pradaxa or dabigatran, Xarelto or rivaroxaban, Eliquis or apixaban, and Savasa, also called edoxaban. And you can see as your score increases, your risk of stroke significantly increases. And this is an annual risk of stroke to be mindful of. So with these blood thinners, there are pros and cons to each. Warfarin is the oldest known of the medications, the most tried and true in many ways. The challenges with warfarin are that many different medications or food interact with it. For example, antibiotics or green leafy vegetables are a problem. It requires frequent blood draws for monitoring. It is inexpensive. Reversal agents are readily available, but there is this ongoing bleeding risk. The newer medications or direct oral anticoagulants were designed to kind of improve upon some of the challenges we face with warfarin. They're actually potentially better at reducing the risk of stroke than warfarin. There are fewer drug interactions, and you don't require monitoring. The challenge, though, is these are newer medications that can be more costly. It used to be that reversal agents weren't readily available, but they are available, though expensive. Bleeding risk. There are lower risks of brain bleeding with these medications, but overall risk of bleeding is about the same. The thing to be aware of is that frequently the medications need to be stopped over 1 to 2 years of use because of either bleeding issues or patients are unable to tolerate them due to other side effects or just stop taking them. And we need to find another solution for some of these patients, especially the ones who cannot take the medications long-term due to bleeding issues. And that's where this device, a Watchman device, comes in. I told you that 90% of the blood clots come from this pouch called the left atrial appendage. And the idea of this device is to implant this mesh device that kind of closes off or walls off this pouch, where it potentially you would heal over it with time, and it smooths out that area. It's about quarter sized. And the idea is you would be on blood thinners for about 45 days after the procedure, a combination of weaker blood thinners for about 6 months after. And if everything looks good, you could potentially just be on a small baby aspirin daily. And this type of device has been studied very heavily in over 6,000 patients, greater than 10,000 years of follow-up, and the device has been shown to be almost as good as reducing your risk of stroke as warfarin and the other blood thinners, but minimal risk of bleeding since you're not taking any type of blood thinner other than a low-dose aspirin. And so the ultimate question, what are the indications for this Watchman device? It's indicated to reduce the risk of thromboembolism or stroke from the left atrial appendage in patients with what we call non-valvular atrial fibrillation, or at increased risk of stroke based on their CHAD score, usually greater than 2 in men and greater than 3 in women, and are recommended to be on blood thinners. They're deemed by their physicians to be suitable for anticoagulation and have an appropriate rationale to seek a non-pharmacologic alternative to anticoagulation, such as bleeding. And as I mentioned, we go through this little algorithm. If you're at elevated risk of stroke, you would be considered, you're suitable for short-term anticoagulation, but you have a good reason ultimately to come off the blood thinners in the long run, and you might be a candidate for this Watchman device. And with this new therapy, we've seen implant success rates of over 95%, very low complication rates of 1.5% or less. Over 92% of patients can stop warfarin after 45 days, and greater than 99% after 1 year. Stroke risk reduction is comparable to taking warfarin, and you have a significant reduction in major bleeding and hemorrhagic strokes, over 70% for both of those. And excitingly, the device has been improved. The third generation of the device is this Watchman Flex, where they've designed it to improve procedural success even further and enhance safety. So I think these are very important considerations for all of our patients to kind of be mindful of who's right for blood thinners, who's right to think about a Watchman device over the long term. Thank you. Then next will be my partner, Dr. Dan Musat.
Can you hear me now? Okay.
Yes.
So I'm gonna share my screen here. And just 1 second. So I was tasked tonight to discuss about one of the lifestyle modifications, and I'm happy that so many people are interested to hear more about atrial fibrillation. Thank you very much for joining us tonight. So I'm going to discuss about the sleep problems that can lead to a troubled heart. And not until recently, people have recognized that actually having problems with the sleeping leads to problem with the heart. And if you look, I have checked into a database of medical journals regarding the sleep apnea and heart arrhythmia. And as you can see, starting from 2000 has been a great interest to evaluate the connection between the sleep problems and specifically sleep apnea and heart arrhythmia. And as you can see, there are around almost 1,500 results, articles about this topic. And indeed, now we start understanding that the sleep quantity and the sleep quality matters. I get asked a lot of times, what is the optimal duration of sleep? And large trials in thousands of people have shown that about 7 hours of sleep at night is just right, about the right amount of sleep. But also what is important, the quality of the sleep and the degree of restfulness and unrestful sleep, it matters as well. And what can plague the restful sleep are insomnia, fragmented sleep, and of course one of the biggest problems is sleep apnea, which can have two aspects: one obstructive sleep apnea and one central sleep apnea that we're going to discuss later on. And what could be the heart arrhythmias that are related to the sleep disorders? Could be extra beats, could be atrial fibrillation, could be pauses like heart stopping, ventricular arrhythmias, the arrhythmia which are more dangerous and occurs from the lower chamber of the heart, and even sudden cardiac death. And if you look at the duration of sleep and the relationship with the increase with the atrial fibrillation, you can see that sleeping more than 6 hours a night is about the right amount. And as I said, around 7, it's even better. However, if you start sleeping less than 6 hours, you can see that the incidence of atrial fibrillation increases dramatically. With if you sleep less than 3 hours a night, the incidence of atrial fibrillation increases by at least 2-fold. And as you can see in this graph, also decrease in sleep time also can result to increased mortality, with people sleeping less than 6 hours a night having an increased risk for death. As we discussed, the sleep quality also plays an important role in development of atrial fibrillation, with insomnia and frequent awakening increasing about 30% the incidence of atrial fibrillation compared with people who do not have no insomnia. And you can see here, all these bullets are towards increasing the risk of atrial fibrillation with insomnia and frequent awakening. Let's discuss about the sleep apnea, which it also plays an important role in sleep disturbances, and treating them can help improve any intervention for atrial fibrillation. There are two types of sleep apnea. One is obstructive sleep apnea, where the airway gets blocked, and usually by the tongue. The tongue falls in the back of the throat, and as you can see here, these are measurements of the airflow, and then it's a pause. Then these movements here are the abdomen movements attempting to take a breath. However, because the airway is obstructed, is impossible, and this results to desaturation or like decreasing of the oxygen saturation. And once it's critical, then you wake up and start breathing again. On the other hand, the central sleep apnea is an interesting phenomenon where actually the brain does not give an impulse for the breathing muscle to contract, for the diaphragm, and you don't see any movements of the diaphragm, of the abdomen, and no breath attempted. And the arrhythmias usually related to sleep apnea are multiple, including atrial fibrillation, non-sustained ventricular tachycardia, extra beats from the lower chamber. And regarding the relationship between sleep apnea and atrial fibrillation, as you can see, people with obstructive sleep apnea have 15 to 20% higher chances to develop atrial fibrillation compared with the people who do not have sleep apnea. And if you have an untreated sleep apnea, the risk of atrial fibrillation recurrence is about 70%. However, if you start treating this sleep apnea, that risk decreases to about 40%, same as in people who do not have a sleep apnea. And if you look also of the impact of sleep apnea and the mortality and the risk for death, you can see that if you have heart failure and also sleep apnea, this is associated with twofold increase in risk of death, regardless if you have central or obstructive sleep apnea. So how you treat this, the sleep apnea? The obstructive sleep apnea is usually a mechanical problem, so you solve it by removing the obstacle. The obstacle, as we discussed, is the tongue. If you can see here, the tongue, this area here, these are the nasal airway, goes in the back of the throat, and usually the air flows in the back of the throat here. However, with the tongue falling into the back of the throat there, it creates obstructions. So most of the times, the CPAP therapy, it's a machine with a mask that pushes the air and usually overcomes the blockage there, the blocked passage there, and keeps the airway open and restores restful sleep. There are some people who are not able to tolerate this CPAP machine, and the solution is a pacemaker-like machine that goes under the skin. It's called Inspire, and it's implanted by an ENT physician, and a lead, a wire is tunneled to the nerve that innervates the tongue. And this machine, it's synchronized with the breathing, and it's giving an impulse for the nerve to stimulate the tongue, and the tongue would kind of come out, stick out, and open the passage into the back of the throat, also improving the obstructive sleep apnea. And if you look at the importance of sleep apnea with in relation with the atrial fibrillation ablation, as Dr. Tina mentioned, you can see here that patients who do not have sleep apnea, or the patient who has sleep apnea but are treating it, have the same success rate after an ablation in the 70s to 80%. However, if you look at the other two lines here, usually in about 40s to 50s, you see that people who have a pulmonary vein isolation or an atrial fibrillation ablation have sleep apnea and are not treating it, have the same results as people who do not have an atrial fibrillation ablation, but they are treating their sleep apnea. Let's discuss right now about the central sleep apnea treatment, which is the same pacemaker type like device that goes under the skin, and there are one wire that goes in one of the small veins going around the heart, which is close to the phrenic nerve, the nerve that innervates the diaphragm. And there is another lead that is placed into the right side into one of the veins that is sensing if a breath is undertaken or not. If this lead senses that there is no impulse for the breathing, then the machine gives a small impulse to the phrenic nerve here, which in turn stimulates the diaphragm and make like call almost a normal a breath. So in conclusion, obstructive and sleep central apnea are related to significant heart arrhythmias. There is an increased risk for atrial fibrillation occurrence and decrease in success rate for interventions if these sleep disturbances occur and are not treated. And there are multiple treatment modalities, but needs to be tailored for each individual. Thank you very much, and I think we'll be open for discussions.
Thank you. Yes, we do have a few questions here. And the first question is, what if you have a CHA2DS2-VASc score of 1 and paroxysmal AFib? What are my options?
Good question. So your risks are kind of stroke versus bleeding on a blood thinner are nearly equivalent. So it's really individualized to the patient at that point. You might opt to continue to monitor. Some would advocate aspirin, or if you wanted to be very aggressive or conservative, depending on how you look at it, treat with blood thinners. Ultimately, though, I think in that setting, if someone has low risk, is otherwise healthy, the goal might be to think about moving towards an ablation, where then conceivably, if we can get rid of the atrial fibrillation, the majority of the underlying reason why you would need to be on a blood thinner would be treated and would not be there at that level of risk. So I think it really depends on each individual patient. I think if you'll ask anybody, 10 different patients with atrial fibrillation, you'll get kind of 10 different stories and 10 different types of medications and treatment plans, because it really has to be customized to each individual.
Thank you. Another patient actually asked, tied to that first question, what is a CHA2DS2 score? And the other part of his or her question is, what are the signs and symptoms right before a stroke?
Sure. So the CHA2DS2 score is a way we assess your risk of stroke. It tells us an annual risk of stroke overall. So CHA2DS2 score is an older version of what I showed in my talk, the CHA2DS2-VASc score. The C in CHA2DS2 stands for congestive heart failure. The H stands for hypertension or high blood pressure. A stands for age, meaning over the age of 65. D stands for diabetes, and S stands for stroke. And the VASc score, the CHA2DS2-VASc score on top of that adds gender and the presence of vascular disease as risk factors. In terms of symptoms for stroke, it can be very different for any individual patient because it depends upon where in the brain the stroke is causing. Some can have no symptoms. Others could be difficulty talking, clumsiness with your hands, difficulty walking, difficulty seeing, among many others. So that's why it can be difficult to first recognize that you're having a stroke and then to seek treatment in an appropriate and timely manner.
Thank you, Dr. Bhatt. Another question we have here is, I've had AFib for several years. I've been told that ablation would no longer work for me. What are my other options?
Well, it depends how symptomatic you are. Some people can live a normal life in atrial fibrillation, and we have to make sure that the rates are not too fast, so the ventricles are protected, you don't develop congestive heart failure, that you're protected from a stroke. The main reason to do an ablation or cure AFib is to make you feel better. So if you don't have symptoms and we can protect you from the complications of AFib, like heart failure or stroke, we don't necessarily have to force you out of atrial fibrillation. You can live a normal life in atrial fibrillation. Most people do feel better in a normal rhythm. So it depends a little bit on the situation. If after years of being in atrial fibrillation, we think there is a chance that we can still cure it, the chance goes down with the duration of atrial fibrillation. Up to a year, it's usually quite doable. After that, it gets more challenging. But if nobody has ever tried to restore normal rhythm and you've been in AFib, let's say for a couple of years, but nothing was ever tried, so nothing ever failed, there's still a chance. It may just take longer because it took longer to get you to this point. So we have to also take more time to reverse all those changes. The chance to restore normal rhythm permanently is definitely lower after being in AFib for several years. But there is an option like the hybrid ablation or using rhythm medications to let the heart beat normal again. It really depends on the circumstances.
Thanks, Dr. Tina. Another question here, it says, I am currently taking diltiazem and digoxin. Do I need to take these meds for life? I also have hypertension and I take Lotrel as well.
And those two drugs are just used for rate control, so they slow down atrial fibrillation. It depends if you're constantly in atrial fibrillation and you need those drugs to slow down the rates to prevent your heart rates from being too fast, then you should probably stay on it. If they're just used in case you go back into atrial fibrillation, you may not need to take them on a daily basis. You can take them as needed. Again, it depends a little bit on the circumstances. Both drugs, they neither protect you from going back into AFib or restore normal rhythm. They're purely used to slow down the heart rate. Diltiazem is also a blood pressure medication.
Thanks, Dr. Tina. Another question here is sleep apnea similar to snoring?
Yes and no. Okay, could be and could not be. It's usually the snoring is a harbinger for a sleep apnea, and people who snore, they tend to have obstructive sleep apnea. Why? Because, you know, the snoring, it's a sign that there is an obstruction in the airway. So it's a reverberation of the tongue in the back of the throat. And in certain situations, definitely snoring can lead to obstructive sleep apnea. And this is why usually everybody who is snoring, we send them to evaluation for sleep apnea.
Follow up on that, at what age would you recommend assessment for a child who's snoring, say a teenager?
I don't think it's any age related. I think everybody who snores should be evaluated for a sleep apnea. And you know, there are some certain features, but that would help us to, you know, to evaluate more who is at risk, higher risk for having sleep apnea than others. And sometimes, you know, like the neck, if a thick neck, and you know, it can tell us that, you know, people are at a higher risk for having obstructive sleep apnea. So I think a sleep test is an easy sleep to take. It's actually done at home. You know, the initial screening test is done at home. I did it myself, so it's not very bad, and I can attest to it. And yeah, I don't have sleep apnea. Okay, that's it. Okay, this was another question, but it's very easy. You wear a wrist and an oximeter on the finger and one a wire and with an electrode on the chest for breathing. So it's actually comfortable to sleep with that machine. And I would recommend at any age, you know, if you snore and there's a risk for having sleep apnea, I think this should be evaluated. And as I said, you know, there are like many devices and many solutions for the sleep apnea, and you know, benefits for treatment outweigh more any possible risk of evaluation.
Thank you.
If I could just jump in to add, I mean, if the specific question about, a teenager or a child having sleep apnea, that, our talk today is kind of meant more for the adult setting. So I would discuss that with your pediatrician. Frequently, children who snore, and if they have sleep apnea, it's due to other obstructions like enlarged tonsils or deviated septums. So, and they could require different treatments, or if they're younger, they may even grow out of it with time. So it's something worthwhile to talk about with your pediatrician.
Yeah, and
Thank you.
For children, they usually recommend the in-lab sleeping tests because they're more reliable. And I guess obesity and those things, it's a little bit different for children. They often have adenoids and tonsils, so they have different features that have to make you suspicious for sleep apnea.
Perfect, thank you. Another question we have about sleep apnea. If one can become compliant with CPAP for obstructive sleep apnea, would it reduce AFib if it's in the early stages?
Yes, absolutely. Absolutely, as I show in my presentation, it actually decreases by almost half the risk of recurrence of atrial fibrillation and the burden of atrial fibrillation.
Thank you. Another question we have, is an ablation appropriate for AFib that is well maintained on rate and rhythm drugs? And also, will the rhythm drug Multac eventually produce side effects?
It's really your preference if you want to maintain on medication or have an ablation. So ablation is always an option if we think there's a reasonable success rate. Almost every rhythm medication will lose effect at some point. It's a little unpredictable how long it will work, but in most patients, the AFib will win and break through eventually. Multac is a very weak rhythm medication. It doesn't usually work for long periods of time. And side effects can develop anytime. Usually people who have side effects develop early on, but they can in theory develop later also. Multac is typically associated with GI side effects. Many people get diarrhea.
If I can jump in, okay, indeed that medications, even if they work at the beginning, usually they stop working at some point. And, this is why we usually quote about 50% success rate in controlling of atrial fibrillation. And usually the atrial fibrillation, it's a progressive disease. So what we do with the medication and with an ablation, we actually stop the progression, okay? And there are some people who actually can stop it for good, but not in everybody.
Yeah, what I would also add is to kind of expand on that. Once you have atrial fibrillation, even if we cure it with ablation, it's a lifelong disease in the sense that you have to manage all those things that Dr. Sichrovsky and Dr. Musat were talking about, making sure sleep apnea is well treated, high blood pressure, diabetes, weight, making sure you're eating right, exercising, so that all the stresses on the heart that are leading to these electrical abnormalities can be controlled as best as possible to prevent it from kind of progressing further and beyond what our current state of the technology of medications or ablations can address with. So it's a combination, not just of medications, procedures, blood thinners, and kind of lifestyle modifications to achieve the highest level of success. You need to kind of tackle all of those things simultaneously and do it over your life to try to prevent it from coming back. And you always have to be on the lookout for it. And that's why even if we treat it, we continue to see our patients at least annually, even if the ablations were successful, to be on the lookout or for other unintended consequences.
Thank you. What can you do for a high D-dimer score of 0.65?
Depends what the cause is.
And what the reason is, yeah.
It's very non-specific.
Yeah.
Unfortunately, that's all that they have written.
Yeah. The D-dimers can be elevated in many different illnesses and in infections, rheumatologic diseases, so it's hard to know. It's not specifically related to atrial fibrillation.
All right, so here's a question about beta blockers. on a low dose metoprolol, 25 milligrams daily to address newly diagnosed AFib, and I'm noticing side effects, including cloudy mind, mild depression, dulled emotions. Are there other beta blockers that don't have these side effects that could be substituted instead? Would an antiarrhythmic like calcium channel blockers be an appropriate substitute for a beta blocker, or would they also have the similar side effects?
There are a lot of beta blockers that can be used. They're like biastolic or bisoprolol. They have less effects on the brain, like depression. Metoprolol it just slows down the heartbeat, so it's not particularly special to treat atrial fibrillation. Calcium channel blockers are also not really rhythm medications. They do the same thing. They slow down AFib. They don't really prevent it or convert it. So within the beta blocker group, the different beta blockers you can try. The one advantage of beta blockers over calcium channel blockers is that often when episodes of AFib are stress related, beta blockers do shield the heart from adrenaline a little bit, so they may work a little bit better. They also dissociate your feeling of having the strong heartbeat. They work better when people are very high, strong, and anxious, but they're not really magic, so you can easily switch to a different medication like diltiazem or digoxin or a different beta blocker, which is less likely to cause those side effects.
So we have another question. Does aspirin work to prevent strokes in AFib patients?
It's a very good question, I think, and I think everyone else can chime in as well. I think historically, aspirin was used very frequently by cardiologists to reduce your risk of stroke if you were kind of in that gray area, the CHA2DS2-VASc of 1 or even 0, to try to reduce your risk of stroke but not have the risk of bleeding. You know, there have been many studies looking at this, and you know, taking a baby aspirin, in my view, is marginally better than taking a placebo or a sugar pill at reducing your risk of stroke if you have atrial fibrillation. If you had strokes for other causes, that's a different issue. So it's marginally better at reducing your risk of stroke, but it does increase your risk of bleeding. So in my view, there's no benefit, just downside to taking the medication at that point. And so it's really an individualized discussion. I think if you have a CHAD score of 0, aspirin is contraindicated. CHAD score of 2 or above, you need to be on another type of blood thinner. CHAD score of 1, I think it's a discussion of a combination of what is the long-term plan in terms of treatment with medications or ablation. And ultimately, if we can do something like an ablation, then and have it be successful, the goal would be to get you off of a blood thinner at that point.
I agree with Advay, you know, and actually the initial indication for an aspirin and for the role of aspirin in atrial fibrillation was based on a study with only a few hundreds of patients, and eventually, you know, larger studies had been performed showing that there is no benefit. Even the quarter about a quarter of the warfarin that was quoted before is not real, and it's taking aspirin is not better than a placebo. Plus, with the newer anticoagulants, the direct oral anticoagulation agents that Dr. Bhatt mentioned, you know, the risk of bleeding with them, okay, some of them show to be equal to an aspirin. So if you take an aspirin or an oral anticoagulant, if you have a choice, it's better to take an oral anticoagulant.
Agreed.
Thank you. We have a couple more questions. Is sleep apnea genetic?
Nah, not really. No.
And if CPAP can improve or eliminate AFib, can I stop taking my meds? I'm taking diazepam and flecainide.
The short answer would be no, okay? Because as we discussed, you know, all the interventions, lifestyle modifications, which are like 4 factors that we usually mention as lifestyle modifications. One is weight management, which is very important. Second is exercise, increase exercise level. third, sleep apnea treatment, and fourth, alcohol use, okay, which we have learned actually in the past year. Several studies have shown that, higher amounts of alcohol actually are tied with the development of atrial fibrillation. So these lifestyle modifications are not treatment for atrial fibrillation, are adjunctive actions that would help any treatment for atrial fibrillation. So if you stop the medications, atrial fibrillation will come back. Do with this lifestyle modifications that we try to improve the results, the medications will work better.
And our other question here is, why does CHAD's score not include stress?
Well, I think stress is a very hard to define. Is it physical stress? Is it emotional stress? And at least it's very hard to quantify. It's very hard to define in any type of studies. And stress in and of itself is not necessarily known to particularly increase your risk of stroke or blood clots directly, that we can actually say in any kind of rational fashion. So the questions we get asked very frequently about, can stress play a role in developing atrial fibrillation? I think yes, as Dr. Sichrovsky mentioned, stress is when we have stress, our adrenaline levels rise. Adrenaline levels can bring out these abnormal heart rhythms, but it's very rarely ever one particular thing that leads to developing atrial fibrillation. I think you compound it, if someone in one person's stress brings out AFib, you might find 9 others where it doesn't, and it's more, and so I think it's hard to kind of figure out exactly what role it is, but we do ask that where everyone tries to kind of deal with every kind of risk factor that might be promoting atrial fibrillation. For example, there are studies showing yoga for stress risk reduction might be helpful in atrial fibrillation, and for some patients it might be helpful in reducing symptoms of the amount of AFib, but it very rarely ever gets rid of it altogether.
Okay. We'll take one more question. Wondering if in the situation that a patient is on CPAP and overcomes risk factors like reduces alcohol intake, loses weight, etc., will the patient be able to stop using CPAP?
Actually, yes. Yeah, we have many success stories about people being able to get off BiPAP, CPAPs, and other decreases the medications with the lifestyle modifications. And indeed, the weight loss improves by a lot, snoring and the sleep apnea. And of course, alcohol also, which is an important factor to lead to snoring and sleep apnea. If the decrease the intake decreases the need for the use of the CPAP. And yes, I have many patients who actually are very happy now that they don't need to use anymore a sleeping machine because of lifestyle modifications.
All right, thank you so much. And then I guess last but not the least, how can the patients take advantage of what the Snyder Center has to offer? What's the usual process? Do they usually have to get referred? Can they just contact the center?
Just make an appointment with one of us. It's very easy.
Perfect.
It's very easy. We have a lot of programs here that the Snyder Center, we look not only at the disease like atrial fibrillation, we look at the whole picture, and we have a lot of specialists that, to help with also with lifestyle modifications. We have nutritionists, we have bariatric surgeons, we have psychologists, and everything, in order to work in concert to help people with atrial fibrillation to improve the lifestyle and the quality of life.
Perfect. Well, thank you so much, Dr. Sichrovsky, Dr. Bhatt, Dr. Musat, for your informative presentation.